Welcome to the Deep Dive Ortho. Now, in the demanding world of orthopedic surgery, few topics are quite as critical, yet or perhaps as complex as navigating medico-legal challenges.
hmm
Every clinician understands the inherent risks, of course, but truly grasping the nuances of litigation, what drives it, and importantly, how you might mitigate it well, that's vital.
Absolutely.
So today we're taking a deep dive into the often surprising realities of malpractice claims, specifically in shoulder surgery. Our aim is to equip you, the listener, with insights to better understand the landscape, manage patient expectations, and, well, ultimately enhance your practice.
Looking forward to it.
Great. Joining me to explore this essential topic is Prof. Mo Imam. So let's kick off with the broader picture. Statistics, they reveal that orthopedic surgeons face a significantly higher risk of litigation compared to the national average for physicians. What's behind this elevated exposure? What's driving it?
That's a crucial starting point. And you're right, orthopedic surgeons typically see an annual litigation rate around 14%,
14%.
which is, yes, double the national physician average of about 7%. And several factors contribute here. Firstly, we've definitely seen a notable increase in patient demands and expectations.
Right.
Often these expectations are fueled, perhaps, by media portrayals of miracle results,
Yeah.
which can lead patients to attribute any outcome that's less than absolutely perfect to a medical error.
The miracle cure expectation.
Exactly. Secondly, the rapid advancements in surgical technology, whilst incredibly beneficial overall, can sometimes create a perception that traditional, perfectly valid techniques are somehow, well, obsolete.
Seen as old hat, even if they work.
Precisely. And regrettably, sometimes superficial or even biased medical and legal reports can contribute to an assumption of guilt against practitioners, which is incredibly challenging to face.
That 14% figure is certainly stark. It really suggests there's a unique mix of factors in orthopedics. Now, given how common it is, rotator cuff surgery often sits right at the forefront of these medico-legal discussions. What do we know about the outcomes of malpractice claims specifically for rotator cuff procedures?
Yes, it's a really key area to understand. There was one analysis looked at 40 cases from a major legal claims database, spanning quite a period, 1988 to 2015. It offers some bare, fascinating insights.
Okay.
So the study revealed that 60% of these cases actually resulted in a defendant ruling.
So the surgeon prevailed in most cases?
In the majority, yes. However, 25% ended in a plaintiff ruling, and 15% were settled out of court. Now, the total liabilities across just those 40 cases added up to over £15 million.
Wow.
And what's particularly interesting here is the financial breakdown. While the average plaintiff award, so when the patient won in court, was around £694,000,
Okay.
the average settlement amount in this specific data set was notably higher, at approximately £1.4 million.
Really? Settlements higher than awards. That seems counterintuitive.
It does, doesn't it? But it often suggests that perhaps cases with higher potential liability or maybe clearer evidence are strategically settled before trial, to avoid potentially even larger jury awards. It highlights the defensive nature of some settlements.
I see. Makes sense from that perspective. What were the main complaints driving these lawsuits?
The most common reasons cited were subjective complaints, pain, and weakness. They appeared in 65% of cases, followed by objective findings, things like limited range of motion, which was present in about 57.5% of claims.
Okay. Pain, weakness, limited movement.
Yes, and orthopedic surgeons were named as defendants in 65% of these specific lawsuits. It's also worth noting that very severe complications, things like death or anoxic brain injury, thankfully rare, they led to extremely high average indemnity payments, often through settlements. We're talking averages around 2.9 million and 3.15 million pounds respectively in those instances.
Huge sums. That really underlines the potential stakes, even if rare.
Absolutely.
Now, it seems logical, doesn't it, to think that the procedures we perform most often would be the most litigated, simple numbers. But when we adjust for surgical volume, the picture seems to change quite significantly. What does the data really tell us about procedures that carry a disproportionately high medico-legal risk in shoulder surgery?
This is where it gets truly illuminating, actually, and challenges those assumptions. You're right, rotator cuff repair does account for the largest raw number of cases, about 42% in one study.
Right, the most common procedure.
Exactly. But when you adjust for how often the procedure performed, it's actually one of the least likely to be litigated.
Least likely. Okay, so what is high risk then, relatively speaking?
Well, manipulation under anesthesia, MUA, emerged as an astonishing 251 times more likely to be litigated relative to rotator cuff repair.
251 times. That's Staggering.
It is. And washout and lavage procedures were 17 times more likely.
Okay.
Conversely, things like injections and total shoulder arthroplasties were significantly less likely to result in litigation, 23 and 14 times less likely than rotator cuff repair, respectively.
That MUA figure is just incredible. What's the thinking behind that? Is it purely about managing patient expectations for stiffness, or is there something else at play? Maybe difficulty proving necessity or success?
It's likely a combination of factors, I think. Firstly, yes, patient expectations for a, perhaps, swift and complete resolution of stiffness after MUA can be very high. Any less than perfect improvement can lead to significant disappointment.
Right. They expect instant relief.
Possibly. And secondly, it can sometimes be challenging to definitively prove the necessity, or indeed the specific impact of the manipulation itself, versus the natural course of the underlying condition. Particularly if the patient's main complaint, perhaps persistent pain or stiffness, remains after the procedure.
Makes sense. It's harder to objectively measure the benefit sometimes.
Exactly. And that same study also highlighted that while court verdicts do tend to favor the surgeon,
As we saw earlier.
yes, settlements can indeed represent a strategic way of decreasing the overall indemnity paid sometimes, with average settlement amounts being significantly lower than verdict payouts in some situations. Not always like the rotator cuff example we discussed earlier, but it's a factor.
So the takeaway for MUA seems to be ultra-clear communication about what's realistic.
Absolutely critical.
Okay, shifting gears slightly. Understanding the fundamental nature of rotator cuff tears themselves must be crucial in a medico-legal context. How do we, as clinicians, differentiate between a traumatic injury and a degenerative process when assessing causation, especially when a claim arises?
Ah, yes. That's a core difficulty, isn't it?
Mhm.
It's a question that frequently comes up in medico-legal practice and in court. Rotator cuff tears can stem from either extrinsic factors, think a single traumatic event, a sports injury, a significant fall,
The obvious causes.
the obvious ones, yes, or they can stem from intrinsic factors, which are typically age-related tendon degeneration. What's often overlooked, though, and studies have clearly shown this, is that a significant percentage of patients, something like 53% with partial thickness tears and 35% with full thickness tears, they don't actually recall any specific injury causing their tear.
Really? That high a percentage?
It is surprisingly high. So very often we are dealing with an age-related degenerative process. This can then be further influenced by occupational factors, repetitive overhead activity, heavy loads, that sort of thing. Now, in complex legal cases, solicitors and insurers might introduce this rather imprecise concept of advancement or acceleration of symptoms.
Right, I've heard that phrase.
Yes, suggesting that an injury perhaps brought forward the onset of symptoms that might have developed later anyway. Now, this isn't really a clinical concept we tend to use day to day,
No.
but it's vital to be aware of it in legal discussions. There's also often a significant inconsistency between just the presence of a tear on a scan and the degree of pain the patient experiences. An initially asymptomatic tear can become painful later on healing. One study showed 51% of such tears developing pain at a mean of about 2.8 years later.
So the link between an event, a tear, and the symptoms isn't always straightforward.
Not at all. It really underscores the difficulty in definitively linking a single event directly to a patient's current symptoms in many cases.
That complexity is clear. We've looked at the numbers, the underlying factors, but sometimes a specific case can really illuminate the whole landscape. Let's delve into a real-world scenario you mentioned, involving a Litarget procedure that ended up in court. What were the core allegations against the surgeon in that instance, and how did the defense respond?
Yes, this case, I think, offers particularly valuable lessons. It involved a patient who underwent a Litarget procedure for recurrent shoulder dislocations. Post-operatively, the patient developed a hematoma, which required exploration, and then about 3 months later, a ruptured long head biceps tendon.
Okay, two distinct post-op issues.
Correct. The claim alleged two main things. Firstly, that the surgeon failed to ensure complete hemostasis before closing the wound, leading directly to the hematoma.
Right.
And secondly, that the surgeon must have inadvertently cut or damaged the biceps tendon during the original surgery.
Okay, so negligence alleged on both counts. How did the defense approach that?
Well, the defense contended that hemostasis had been achieved satisfactorily at the time of closure. Any rebleeding, they argued, occurred later, perhaps due to clot displacement or a ligature slipping, which can happen.
A known complication, essentially.
A potential, albeit unfortunate, complication.
Hmm.
Regarding the biceps tendon, the defense argued it was highly unlikely to have been injured during the operation, given its anatomical position relative to the surgical field for a letargit. And the fact that the rupture occurred 3 months later strongly suggested it was a non-negligent post-operative event, not a direct intraoperative injury.
Right. The timing seems key there.
It was. But what's truly striking about this case is that even after a joint meeting of the independent experts, one instructed by each side, who agreed that an arterial vessel was the likely cause of the hematoma and should theoretically have been identified by proper inspection, the case still proceeded all the way to trial.
That's incredible. Even with expert consensus on the likely cause, it still went to court. Why?
It highlights the complexities and sometimes the determination in legal proceedings. Perhaps the claimant's side still felt there was a case to argue regarding the standard of care during inspection, despite the agreement on the vessel type.
So what was the court's final decision after the trial?
After a 3-day trial, the judge ultimately dismissed the patient's claim in full.
Dismissed.
Yes. The hematoma was found to be a secondary complication, not due to a lack of reasonable care or negligence during the surgery. And the biceps rupture was deemed an unexplained, non-negligent complication.
A vindication for the surgeon, but stressful nonetheless.
Extremely. This outcome really underscores how claims can be pursued right up to trial, even without clear, objective evidence of negligence. And that process can be incredibly distressing and take a significant emotional toll on the surgeon involved, even when they ultimately prevail.
Absolutely. That letargit case really drives home the unpredictability. But stepping back from specific cases, what are the broader common complications after various shoulder surgeries that clinicians should consistently be vigilant about, as they often give rise to these malpractice claims?
Yes, there are several recurring themes, and it's absolutely essential to communicate these clearly and very thoroughly during the consent process. Infection, for instance, is always a background risk.
Of course.
Though thankfully, arthroscopic surgery has significantly reduced the deep infection rate. It's now generally under 0.5%, compared to maybe over 1.5% for some older open procedures.
That's a significant improvement.
It is. Stiffness is another quite common issue, affecting perhaps 5% of cases postoperatively. It's often temporary, but it can take quite a while, sometimes 12 to 18 months, to fully resolve. Patience is key there.
And nerve injuries.
Nerve injuries, though thankfully rare, can be devastating when they occur. The axillary and musculocutaneous nerves are particularly vulnerable, maybe from traction during the surgery or, less commonly, direct injury. This risk is perhaps slightly higher in complex cases or revision open procedures where the normal anatomy might be distorted.
Right. Altered anatomy increases risk.
Definitely. And even the interscalene nerve block, which is commonly used and very effective for pain relief,
Right.
well, it carries its own small but real risk, estimated around 0.4% of either prolonged anesthetic effect or, in some cases, long-term nerve pain or complex regional pain syndrome. It's crucial that patients understand these possibilities up front, even the rare ones.
Absolutely. Setting those expectations clearly. So we've navigated common pitfalls, surprising risks like MUA, but as we move to more complex procedures like shoulder instability surgery and shoulder replacements, what are the unique medico-legal nuances surgeons need to be acutely aware of with each of those?
Yes, both present, distinct, and significant challenges from a medico-legal standpoint. For shoulder instability, the first crucial step is correctly recognizing the type of instability. Is it traumatic resulting from a specific injury? Or is it atraumatic, more related to inherent ligamentous laxity?
Why is that distinction so critical?
Because atraumatic cases in particular genuinely require management by a highly specialized shoulder team. Inappropriate stabilization surgery in these patients trying to tighten things up too much can significantly increase morbidity, worsen their symptoms, and lead to poor outcomes.
So patient selection is paramount.
Absolutely. While the recurrence rate after modern stabilization surgery for traumatic instability is relatively low, around 5% perhaps, errors in recognizing the underlying pathology, selecting the right patient, using the correct surgical technique, or even errors in the post-operative rehabilitation protocols can severely compromise the final outcome. And that naturally dramatically raises the litigation risk. It really boils down to ensuring the right procedure for the right patient performed by the right experienced team.
Makes sense. And what about shoulder replacement? That's becoming increasingly common.
It is, and here, the indication for the replacement, whether it's for severe arthritis or for a complex fracture, carries very different risk profiles and, importantly, different expected outcomes.
Oh, so?
Well, replacements performed for complex fractures are often essentially salvage procedures. They aim to improve function and reduce pain, but they rarely achieve a normal shoulder feeling or function. The satisfaction rate tends to be lower, maybe around 75%, especially in older patients with our poor bone quality, osteoporosis.
Right, managing expectations is key there, too.
Critically important.
Mhm.
Whereas total shoulder replacements for osteoarthritis generally boast excellent outcomes, often over 90% pain relief, and perhaps 75% functional improvement reported in studies. However, and this is a key point, studies strongly indicate that surgical outcomes and complication rates correlate directly with the surgeon's specific expertise and their case volume.
Experience matters.
Significantly. For instance, some data from the USA suggested that a striking 75% of shoulder replacements for arthritis were performed by surgeons who only do 1 or 2 such procedures a year.
75%.
Wow. Yes. Which strongly suggests that patients may well achieve better results with fewer complications if they're treated by high-volume specialists for these complex procedures.
That's a powerful point for patients and referrers to consider. Are there specific complications and replacements we should highlight?
Yes, specific risks to be keenly aware of and discuss include things like glenoid prosthesis loosening over time, postoperative instability or dislocation, and intraoperative paraprosthetic fractures occurring around the implant during the surgery itself. These are more common in softer osteoporotic bone.
Okay, a lot to consider there. So bringing it all together, what practical steps can you, the clinician listening, proactively take to genuinely reduce the risk of malpractice claims in your shoulder practice, going beyond just, ticking the consent form boxes?
This is perhaps the most important takeaway message for every practitioner. The absolute bedrock is thorough, clear, and effective patient communication.
More than just the paperwork.
Far more. It means explicitly emphasizing the inherent difficulties of the specific procedure being proposed, discussing all realistic risks and benefits, not just the common ones, and crucially, setting realistic, achievable expectations regarding the likely functional outcomes, the potential for residual pain, and maybe ongoing weakness. It's about empowering the patient with comprehensive knowledge.
Including the possibility things might not be perfect.
Exactly. Including the possibility of continued pain or limited motion, even after a technically successful surgery. Secondly, meticulous documentation is just paramount. A clear, comprehensive, and contemporaneous record of the entire consent process, discussions about the alternatives, the planned rehabilitation, post-operative instructions, and follow-up care. It's invaluable. It forms the backbone of any potential defense.
Your notes are your shield, essentially.
In many ways, yes. Furthermore, continually maintaining and actively enhancing your surgical expertise is key. Being proficient with the equipment you use, utilizing modern implants where appropriate and evidence-based, and particularly for complex procedures, ensuring you have the necessary specialist training and ongoing experience.
Staying current and skilled.
Precisely. And finally, I think every clinician should diligently track and audit their own results, understand your personal outcomes, know your complication rates, and identify areas where you can make continuous improvements. This kind of self-reflection is a powerful safeguard in itself.
That's excellent advice. Thorough communication, meticulous documentation, ongoing skill development, and self-auditing.
That sums it up well.
Well, we've certainly covered a lot of ground today, exploring the complex world of medico-legal challenges in orthopedic shoulder surgery. It seems clear that while the risks are undoubtedly real and perhaps even increasing, understanding the data, refining our communication strategies, and committing to continuous improvement in our practice are undeniably powerful tools for mitigating them. And if you found this discussion valuable, please do consider rating and sharing it with colleagues who might also benefit. Prof. Moimam, thank you so much for sharing your invaluable insights and experience with us today.
It's been my pleasure. Thank you for having me.
As we conclude, perhaps consider this. In an era of increasing patient expectations and these rapid technological advances we've discussed, what specific aspect of your current practice might benefit most from a renewed focus on medico-legal vigilance and, perhaps most importantly, on that truly effective two-way patient communication? Something to reflect on. Join us next time for another deep dive.